Emergency room is really difficult because there's so many random things. It's kind of telling as to how difficult it is to work in the emergency room because you got all ages, any kind of issues. Now, a lot of times it's the usual stuff, abdominal pain, Dilaudid Zofran, a liter of fluid, and some CT contrast, and you get your CAT scan done, and most of them, we could have probably stopped at the Dilaudid and Zofran, and the other ones need to be admitted for something or need surgery or whatever. So that's probably one of the most common things. And then depending upon the time of year, respiratory stuff. In the spring, there's a lot of trauma because people are doing dumb things. The alcoholism and all the things that go with that are pretty much a year-round event. So I'm just going to kind of throw some random things out there because that's kind of what it is, right? So bioterrorism, what I would do is I think there's some conditions listed under bioterrorism on your objectives. So like anthrax, smallpox, I don't know what else is on there. You want to know just because you're not going to be able to spend a lot of time studying for this piece because the cardiac stuff is most of what you need. The shock stuff, I think you guys pretty well have. So you're going to be studying a lot of cardiac most likely. So the ER is going to be a little more challenging perhaps to cover. So you need to know, what do these look like? So if I had a patient come in and they have signs and symptoms of something, what would anthrax look like? What would smallpox look like? And then how do you treat it? How do you isolate it? So isolate and treat. Okay, so you can make a table, draw a picture, whatever you want to do. But that's probably the best way to attack that. I would not get real deep into labs or vitals, because the thing that we're concerned with bioterrorism is the threat to the population. So you got to get it identified and contained and then treat it. Okay, so I know there's a couple of other ones, but that's what I would recommend. And you can go online and you can find all kinds of pictures. Find something that speaks to you and go, okay, this is my anthrax poster child, whatever, right? We had an anthrax scare. It's been a long time ago now. It feels like it wasn't very long, but it's like those memes where 20 years ago was the 80s, and you're like, well, no, not really. Anyway, some of you probably weren't even born then. So where was I going with that? Oh, my Lord. Oh, we had an anthrax scare. So there was like somebody licked an envelope and got sick and whatever, right? So then everybody got terrified that they were going to get anthrax. So everybody went to Mexico and bought all the Cipro. So then guess what? We had a Cipro shortage because there was no more Cipro because everybody bought it to, treat their anthrax. But perhaps that will make you remember that we treat anthrax with ciprofloxacin, which is a fluoroquinolone. So that's bioterrorism, identify, isolate, and then treat. And then there's the community concerns. As far as trauma goes, so trauma, we're concerned about bleeding and poking holes in things. Broken bones. And anything that is above the waist could potentially cause a respiratory issue. And then, of course, we've got bleeding, we've got airway. That's what we're most concerned about in the beginning, right? If you've got penetrating wounds, I used to show a really gnarly picture with a guy with a big knife sticking in his chest. It looked like out of one of those cutting things, like a kitchen knife. So what's the rule for that?
Keep it steady.
Yeah, just stabilize it. You let the doctor pull it out. Not like in the movies where the first you're like, no, don't pull that out. That's the worst thing you can do. And they bleed everywhere and die. So penetrating wounds, you just stabilize the wound. Do not remove the weapon or whatever it is. And if you have blunt trauma, then of course everything that is in that area of blunt trauma could have an injury, right? So the entire area you want to look at. So if they had a motor vehicle accident and they hit the steering wheel and they've got a gnarly seat belt mark on their body, then that whole area where you can see the seat belt, it's all potential injury. And so that's what would need to be assessed, CT scan, x-ray, that kind of stuff. But then you're still concerned about bleeding. It's almost easier if they have a penetrating because you can see exactly what's wrong and you can go treat that. When it's blunt, sometimes you don't see it right away or they've got a slow bleed or something. So until they crash from hypovolemic shock, you don't even realize that they're bleeding necessarily. It just kind of depends. Okay, so that's trauma. What else is there?
Dr. Whittick, please call 5311. Dr. Whittick,
Trauma,
5311.
bioterrorism. Triage. So I wouldn't worry about, there's all the different levels of triage, right? So we're going to triage based on what the patient requires. And we're not going to get into all of it, and you don't need to know all of it unless you go work in the ER. But they look at things like this patient only needs one, and I can't think of what the heck it's called, one service, and that's not right. They only need like one resource. They only need like one resource. So they just need a prescription refill, or they just need a breathing treatment. So that person is going to be triaged low on the totem pole into a fast area, RME perhaps, which is rapid medical exam, fast track, urgent care. Those are all the same kinds of things. So we get those guys over to the side, and most ERs have like a PA or an NP that's going to just try to get them in and out real quick, okay? Then we have the ones who come in and we cannot save them. They are, they might not be technically dead on arrival, but pretty close, and there's not really a lot to save. Remember, there's two different kinds. So there's like regular ER triage, and then there's disaster triage. So disaster triage is you save the ones you can save. So this is where you have the scenario of there was an active shooter at the school, and so you've got a flood of people coming in, and the ones that you know that you can't do anything with them, those are the ones that get flagged as, I'm sorry, we can't treat you, and then we're going to go to the next one. So you look at what your resources are and who you can save, and those are the ones you can treat. That's different than your regular triaging, where are they going to the trauma room, or are they just going to a regular ER bed where they need like 3 resources, so they need some IV fluids, they need an EKG, they need some labs, that kind of stuff, okay? So, and then the other thing with triage is the red flag type patients. You should have a list somewhere. So the people that have a high potential of decompensating, they might come in and look okay, but you want to keep an eye on them because you know they could go bad any moment. So things like a motor vehicle accident over 35 miles an hour, they could come in and look fine. And then, they crash because they've been bleeding somewhere. What are some other red flags? Like a chest pain, yeah. So we can talk about this more tomorrow, but, so that would be something, what are those patients that, though they might not need much right now, they do need watching, okay? So you should have kind of a little list of those things. There's some things like vital sign change, this to this. So that's something that you need to investigate, the red flags. Safety in the ER. Not just safety of the patient, safety of the staff. It's a very dangerous place. Patients are unpredictable, and it's often chaotic, and so everyone's safety is at risk, and so you want to be aware of your environment. And we usually try to put like people that are having psychiatric issues into one area to kind of keep an eye. At Palmdale, we have a corner where there's only one exit called the psych corner because it's more manageable. You could put somebody at the exit and that's the only way they can go in or out, you know. So for safety. So we try to keep things like that separate, but it can be really difficult. And they can come in without, you know, how much security did they get? Metal detector, no metal detector. Have we looked in their pockets or, you know, their boots, whatever, okay? So those are all things that could cause safety issues. Okay?
It was poisoning too. She didn't go for
Poisoning. So when we get a patient that's been poisoned, we rely on poison control. And we actually will call them and say, this is what happened with our patient. They drank antifreeze. We don't know how much, at least half a gallon. I don't know, I'm just making this stuff up. What do we do? So as far as nursing care goes, we're going to support their vital signs and make sure that those things remain stable, keep the patient safe, give them fluids, you know, all that good stuff. Poison control will say, okay, well, we need these labs, and this is how we're going to treat.
5244. Dr. Perret, 5244.
And then they will call in and check up. So they're kind of managing the patient. The physician still writes the orders for whatever the poison control recommended, but we're really doing what poison control says we need to do based on, was it a spider bite, snake bite, antifreeze, you know, whatever, okay? We do not induce vomiting because coming back up could cause more of a problem, right? We have a lot of, in the Antelope Valley, we have a lot of pools. So there's like muriatic acid, there's all kinds of pool chemicals and things, so that's partly why we rely on poison control, okay? So if there is an antidote, of course we want to give the antidote, and usually there's a lab or something that we can do and criteria to follow to tell us like how much of the antidote to give, what the signs and symptoms are, if they're getting worse, okay, that kind of stuff. And then we're going to support the vitals. Think about, you know, we're flushing out of the system, so we're going to want to give fluids. And if there's a marking, we want to mark it and watch for, like, if it grows. So if you have a spider bite, we're going to take a wound marker and we're going to draw around the borders, and then we'll be able to see if it expands or gets worse. I had a patient a long time ago who sat on a brown recluse spider. They lived out in the sticks, and it looked like a burn. We treated her like a burn patient, and actually we airlifted her out from sitting on a spider. So I got her like at the beginning of the shift, and of course it's on her behind, so, you know, poor thing. So everybody wanted to look at her behind because it was the spider bite. But it was like eating away at the flesh. Like it was still, like it was a burn and it kept burning. And so when I got her, everything was intact, but you could tell where the bite was, and we marked it. And by the end of my shift, it looked like a stage 4 wound. It was crazy. And I don't know what happened to her, but there's a lot of fluid loss and infection risk, and that's the only time I've seen that kind of a thing. But yeah, they sent her to a burn center for treatment. So she actually was like a septic patient, which is why she was in the ICU. And so we had to give her the fluids and vasopressors and all of those kinds of things. Okay? Sometimes they even bring you whatever it was that bit them in a jar or a baggie or wrapped up foil. You've probably seen some things, I don't know. So poisoning. So then sometimes they need to be intubated to protect their airway, depending upon what the scenario is, right? We give antidote. We can also give charcoal, activated charcoal. And it looks like somebody took some coal and ground it up into powder, and we put that down the OG tube. So my first encounter with charcoal, we get this patient from the emergency room, and she's intubated. She's got her OG tube clamped. And they said, okay, we gave the charcoal. So there's some black in the tubing. So yeah, okay, you gave the charcoal. And I had a new nurse. And I was going in the room to, see what they needed. And they walked out, looked like a chimney sweep. Because when your patient coughs, if your tube, because she was undoing the NG tube, it just went everywhere because it's charcoal, right? And it was all over the bed. I mean, it looked like a charcoal bomb went off. Poor thing. Yeah, we laugh about it now, but. And I've had a patient drink it because they weren't intubated or anything, and they did it, huh?
They say it's really nasty.
Well, I wouldn't eat a piece of coal either, But it binds to the drug. So, I mean, it can work. And then some things need to be neutralized with an alkaline or, whatever. So it's really specific to the particular poison, but these are some kind of random things that you need to look for.
How is that excreted from the body? Urine or stool?
Stool.
Okay.
Yeah,
I was just
they have
wondering
black poop for a while.
Their pee turned
Mhm.
black.
I don't remember if their pee changed color. If your patient has blunt trauma or they're found down where they have muscle damage, so the alcoholic guy that passes out at the gas station and he's been laying there for hours and hours and hours, that muscle that's been laying there under pressure, just like a pressure sore, gets damaged. And when your muscle cells get damaged and they break, myoglobin comes out. And myoglobin is big, so it gets trapped in all the little vessels, and it can cause acute tubular necrosis. So if we have muscle damage, and our CK will be super, super high, we're talking, could be 10,000. It's just a non-specific measure of muscle damage. It can cause acute tubular necrosis, and your urine will turn red, so that's how you know that you've got muscle damage. But it can cause a lot of perfusion issues because that muscle tissue, those muscle cells, are a lot bigger than your normal, the normal cells that are floating around in your body. And so you can get symptoms of having clots. You can lose circulation somewhere. That can also happen with, I don't think, you guys haven't done burns yet. But when you do, when you have like electrocuted patient or lightning strike or something, the whole pathway of the electricity could cause muscle damage. And so then you end up, and they call it rhabdomyolysis. Rhabdo. So that's kind of what that's all about too. So that can also happen with a trauma, especially like a blunt trauma, something that you can't really see as well, or it's just bruised. Okay?
You have the I was just looking at the page.
Yes.
The psychiatric emergency.
Psychiatric emergency.
Mental health and response.
I didn't hear most of what you just said. I just heard psychiatric emergency. I'm sorry. Safety is going to be the biggest issue, right? Remaining calm, not getting the person all upset, and they're going to need an evaluation by the PET team, psychiatric evaluation team. Some hospitals have them on site, some do not. So, for example, at Palmdale, we have to call an outside service, and they come in and do the eval, and they don't have a psych unit, so then they usually have to ship them out. Sometimes they stay in the ER for some time, which is not good for anyone. Here, we have a mental health unit, so if there's a bed, and they meet the criteria of the mental health unit here, they can stay here. But we would need to identify, do they just need meds and stuff, or did they suffer some kind of traumatic event, or are they unsafe and they need a sitter and a 72-hour hold and all that good stuff? Okay.
Sexual assault.
Oh, okay, so the sexual assault, domestic abuse. So we have and they keep changing the acronym. Sexual assault response system team, however you guys know it, but there's a group of people specially trained to deal with that.
SANE nurses?
Huh?
SANE nurses?
SANE, yeah, SANE. It's all about the evidence. It's all about collecting evidence. That's all you really need to know. And you can't, so I was talking about those test-taking skills, they fit this very well. We do not persuade. There's nothing we can do about the cycle of violence except educate and tell the patient what their options are, treat the injuries, document well, but it can be very frustrating. So collecting the evidence, so whether it's their clothing, if there's going to be like swabs and different things done, usually the SARS unit will come and do it, but you want to make sure that the patient doesn't get cleaned up or any of that kind of stuff, because again, it's all about the evidence. Okay. Anything else? That's probably good for now.